Hello everybody, it's Martin Kiernan here, talking to, this time, Sinéad Horgan. Now Sinead works in the School of Midwifery at the College of Medicine and University College Cork and in the Department of Nursing and Midwifery South-Southwest Hospital Group. And Sharon has a bit of a journey talking to me about surgical site infection surveillance and some studies she's been doing recently. So welcome Sinead, thanks very much for sparing the time to have a chat to me.
Oh, thanks for the invite, I'm greatly honoured. And I'm listening to your podcast now. It's really good, very informative.
Yeah, the surgical site infection ones have been very, very popular, and it's clearly a hot topic. I mean, you won the best poster abstract at the IPCI conference last week in Dublin as well, which is quite nice to see. So people clearly are recognising that, although conflict there. I was one of the judges, but there we are. So how did you get firstly engaged in surgical site infection, and what led you down this path that you've been on for a few years now?
Yeah, I suppose my background really was surgical. For many years I worked up through the ranks in theatres across a few hospitals here in the south of Ireland as C&M as well. I suppose firsthand I could see infection there. From that post, I went into a national post with a local remit for sepsis here in Ireland. So you can see there the surgical and the sepsis piece keeping in. So for the last 7 years, I suppose I've been doing audits in the hospital on the wards. And I suppose you're acutely aware of the surgical returns and of, the crisis of sepsis, and that the problem, even though we think it's there, we never really can quantify it, of those patients that are suffering from infection after surgery. So my interest started there, I suppose. Back in 2017, the opportunity arose to do a PhD, and I felt that this was an area from my background that infection with surgery mix and preventing sepsis, I suppose. And looking then, I suppose I had the opportunity to go over to Public Health England to one of those training sessions in 2017 with Pauline Harrington, on SSI, and I could see from the room and what was going on nationally there. And I just felt we were a little bit more behind, I suppose, in Ireland, that there wasn't that engagement and there of even firstly collecting data and then seeing the huge work they were doing around quality improvement. I suppose a bit of envy crept in, really. Now I knew from talking to Health Protection here in Ireland that there was a plan to move forward with this, but then of course, what happened over the last few years with the COVID pandemic. I suppose we were set back a little bit. So that's really the background to it. I suppose there was a national aim at the time under Health Protection to next look at surgical site infection and to start collecting data, and then the rest would follow. Now we're under AMRIC, and AMRIC have a plan here in Ireland, which really was great, welcomed really, their 22 to 25 action plan, which first says that we're going to look at fractured hips and then followed by cesarean sections. So I had done a little bit of work locally here. So, yourself, you can't beat having national policy guiding what you're doing. And even though I was looking to literature and the guidance that's in the NHS and ECDC and CDC, you can't beat that national push now as well. So that brought me to that, and I suppose I've done 2 systematic reviews, and the first one on the impact of a quality improvement initiative on the knowledge and attitudes of healthcare workers, healthcare professionals in relation to surgical site infection and prevention. And the second systematic review was on the impact of quality improvement intervention on the incidence of surgical site infection in colorectal patients.
Can we talk briefly about the attitudes ones? I mean, you're saying knowledge is poor. Yeah. Do you think that's because people don't recognise infection if they're working in that field? Because many people who, when you know yourself, I've worked in theatre, you don't actually often see most infections because they be dealt with on the ward or by GPs, and it's only the most significant ones that actually come back into theatre. So do you think there's a recognition amongst people who actually are involved in preventing infection, in recognising that it exists?
when you look at knowledge and attitudes, I think you can't just look at one cohort. And sometimes if you just look at theatre, exactly what you confirm there, you only know what you see. Whereas I think surgical, on the surgical floor or in outpatients, the knowledge and attitudes are that bit different, because they see these rumbling infections that possibly wouldn't go back to theatre, or they're redressing wounds that go on for continued. Like, I think from the literature review and from the research I did on knowledge and attitudes, they both more or less reflect each other, where attitude, nobody wants their patients to get an infection. And attitudes are generally good. Whereas knowledge is pockets, if you're talking to infection control nurses, they seem to be a variant there to the maybe theatre nurse, or to the, the doctor, or to the GP. In relation to knowledge generally is poor. We don't use the terminology that's there. We don't classify as we should do. And sometimes even that conversation, and I know everyone that's been involved in surgical side will recognize this, that conversation with a surgeon who says, no, that's a collection. And you're kind of saying, well, if you look at it, you drained it, you sent a sample, it came back as positive. Hence, it is an infection. And that debate, knowledge, even in front of somebody, is poor. Even having all the criteria in front of you. So I think the whole quality improvement aspect of it is, we talk about quality improvement as if we're going to introduce something wonderful, and it's something wonderful is going to come out of it. But something wonderful is discussion, is something wonderful is teasing a particular case out to get to a kind of a common ground where that understanding is there, and it's building on that understanding. And I know anyone that, and you're including yourself, that have had those conversations, even if you are chasing someone down the corridor saying, look, it looks like a duck, it quacks like a duck, it's a duck. That conversation is quality improvement, and is interventions that come out of having data. So we know that surveillance on its own, I think another thing is knowledge of what surveillance is. Surveillance, I think when we think of surveillance, we think of, you watch something. But of course, the definition of surveillance is you watch something, you see what you found, but you act on it. And that's the last aspect of the definition of surveillance. But I think, if you were going to do surveillance on something, anything other than infection, surveillance, I think most of us think it's just collecting and watching. And it's so much more than that.
How did you manage to get it implemented then in your organisation? Because, as you say, it's not a common thing in Ireland. So you're starting from scratch nationally, effectively. So how did you manage to get people on board? How did you go about that?
And you see, that's it. And I think that, Carol May, he's that normalization process theory. And drawing on theory and going back and looking at theory. And when you read it, they say, Carolyn Finch, that you need cohesion, you need collaboration, you need cohesiveness. And that's exactly what everything I've been involved in that's been successful, I suppose, even if it's sepsis or surgical side, has been that. Having the right people at the table, having people that have a common interest and common ground. And I think that you can't achieve any of this unless you have that. And how'd you get people to the table? I didn't. First day I didn't. I got the first meetings I had on the project I ran in the hospital here. There was about 5 people came to it. And they ran over an 18-month period, and the room was full by the end, because I think the key thing here is, and looking back on it, is engage with those that engage with you. And once you start working with them, it's word of mouth. It's slow, but it's word of mouth, and then it's the quality. Like, if someone had told me, and I said this before, that when I started this project up there in that hospital around the colorectal piece, and now we've done further hospitals since, and I've been able to replicate what I did in the first hospital in other hospitals. It is actually going and doing a retrospective look at what you have, creating that problem statement. But I'm always shocked at what you set out to do first day is never done in the process you imagine it will be done in. And starting out up there, it was sole aim is to reduce SSI rates and to engage with others to do so. And I had in my head that, we'll introduce this, we'll bring in a care bundle, whatever. And I had all these ideas, assumptions in my head that this would go as I thought. But what we ended up doing was doing a patient information booklet. And it's because, but it's a 48-page patient booklet. Now it's part of our intervention that is continuously improving patient outcomes, which is great. But it's that sitting down with everyone, and it was everyone deciding together, we need a booklet. We need the patients to be more informed about every aspect of it, of their care and their perioperative journey. In the back of the booklet is information on wound care and the post-discharge questionnaire, but it's about so much more. So we don't all work in silos, we work together. And that's what brought everyone on board. The physiotherapist wanted their bit and their contribution on reducing SSI, mobilizing, the dietitian wanted her bit to, and her team's influence on it, on how a good nutrition can prevent surgical site infection. And then the other allied health professionals came to the door. Then the antimicrobial pharmacist wanted to put in a bit. But then her colleague, the pharmacist on DVTs, wanted to put in a bit. And then it was...
So they're all coming to you. This is what my daughter would call FOMO, or fear of missing out, isn't it?
Fear of missing out. But, there's challenges there too. While it was fantastic, the colorectal surgeon, who was a big, big influencer in this, and he was
positive or
amazing,
negative?
A positive. He was a champion for this. He was. However, we are challenged, I think, going forward, because they are interested in their own cohort, but having a lead to collectively look within a hospital, a surgeon, you'd want the lead of the surgeons to be the driver, someone that can influence every cohort and ensure that they're at the table.
Of course, the lead doesn't have to be the person who's named as the lead, because I've seen medical directors who go for the job of medical director, but they're not necessarily the best leader. They've just been somebody's applied for that job. So actually, your colorectal surgeon, who's being a fantastic advocate, possibly is the de facto leader, in that he's got enthusiasm which may be transmitted to others. Did you find that?
Definitely, because I think once we started with colorectal, cardiothoracic came soon knocking at the door. We like what you're doing. Having said that, those that probably have a problem, we don't see them coming very often, but I think this is a rolling effect. I think once it starts, it takes off. And but it's sustaining that model. And I suppose that was one of the key things, I suppose, that, we look at the barriers and the enablers for this, and I think Trockton has that lovely paper on, the hierarchy and all of the things that affect rolling out a project such as this, or an initiative such as this in a hospital.
So which paper was that again? Because the sound just went slightly then.
Rachel Trockton, I love that paper.
Okay.
It talks about the enablers and the barriers, and it's a qualitative research, and I thought that was just a great paper. It also leads into findings from my systematic review, which are, and this is, everyone is nodding at this, I imagine. You have to sustain it. You have to have a facilitator. You have to have that engagement, and you have to have management buy-in, driving this from top down, and you have to have the floor engaging in it. But I think the engagement piece, I found, even when we did C-sections across 2 hospitals here, engagement from people isn't a problem. As I always say, nobody wants their patient to get an infection. I think that's why you find attitudes, and in the research I did, attitudes were very good. It was the knowledge that was lacking. And the questions I would have asked about were, the classification of SSI, the wound contamination classification. That's huge. That's new to people. Yeah, and I know you're in the journey a long time, and I'm sure from listening to your colleagues, that getting that across the line is big. That's a PDSA introducing that. You need a facilitator to drive those bits to get, because it's only through collecting the risk index, and all the variables, that we can actually create a picture and support surgeons. I think selling that was a big thing. Telling surgeons, if we have the risk index, it kind of explains your patients, the cohort you have, and they like that actually, because it moves away from that blame that it's you, the surgeon, you did something wrong, or your theatres did something wrong. It actually creates a picture of our patients and what we're seeing now: older patients, sicker patients, patients on suppressive medication, patients. Like, not only is quality improvement around SSI complex, but the patients are complex. They're getting.
Yeah, I mean, do you think having that
complex.
risk factor? Do you think having that risk factor information actually makes them more likely to make sure they've implemented all aspects of a bundle, knowing just how risky a patient has?
Yeah, now I see that. We have electronic patient record in 2 sites here, and they do see the value, because it doesn't let them move on when they're writing their off note unless they put in their clean contaminated. That needs to be put in. And I think once you explain it to them, you see them, a light bulb going off, that this helps them. Because and then explaining your risk adjustment thereafter. So you have your infection rate and you have your risk adjusted infection rate. That's critical, And I think that piece too of engaging surgeons, especially when it comes to teaching and I suppose publications, they all should have an interest in their 30-day mortality and their 30-day infection rate. I mean, these are their key performance indicators, really, so
But if they don't know what the rate is, it's difficult to be interested in it, isn't it? I mean, they obviously know mortality, but if they hadn't previously known the infections, now you're giving them new information.
Yeah.
How's that gone now? You've managed to provide them more information. You've got positive change in knowledge, would you say?
Yes.
Because the attitude was good anyway?
The attitude was good. The attitude just improved slightly, significantly, in 2 areas where the staff now realised in the post-intervention that, yes, we monitor our patients, whereas before it was just a little bit less, And yes, we follow up and we are collecting information on our patients after they leave. So, sorry, I went off the point there. You asked...
Well, it was the change in, the positive effect of having this information. How does that translated into changes in practice, maybe, or changes in bundle compliance, or changes in infection rate? You
see, I suppose we were in at the beginning here, but the infection rates when we started, and there's a paper on this, we've published this, for colorectal was 25.3, and we didn't have a post-discharge on that, but colorectal, so it could be underestimated. So then a year later, we redid it after starting surveillance and some small changes, and it came down to 15.4. And then we introduced the booklet and other elements, newer elements to the care bundle. And then it saw it come down again to 11.4. So when you have that improvement rate, it does bring about, okay, we're doing something good here. This is good. We're onto something. And I think it's that gap that's there in clinical practice that where, when they can tangibly, when they can see improvements, it's
a confidence equals success spiral almost, isn't it? It takes me back actually to many, many years ago. I used to navigate on road rallies, and I was running near the back of the field. And one night, a guy who was running right at the front of the field said, "My navigator can't do it. Can we do this?" And I did it. And we finished, I think, 3rd. And we had been running car 1. And I'd never finished in the top 30.
Yeah.
And afterwards he said, "Right, now you have the confidence." And he just drew on a piece of paper the word success, confidence, draw an arrow, a double-headed arrow going in both directions.
Yeah.
And I never finished out of the top 5 again.
Oh, yeah.
Just because I suddenly believed I could do it. And that's what you have, isn't it? They see success.
Yes.
And now they think they want to try even harder. So it's like a snowball coming down a hill, isn't it?
Oh, it is. And it's like... But I do think that's why it's complex, and it's, these complex interventions we talk about, it is complex because it never happens unless all the cogs are going, and okay, you can manage without one or two, but true success if they're all moving in the end, but I think it's that the facilitator piece, the national policy, management involvement, and that drive. And I think the one piece we keep forgetting here, I suppose, is the patient participation. And all the literature now says we should be including our patients. I mean, we should know how our patients get on when they get home. We provide a service. Yeah. We need to follow up with them. And what I found over the last few years is, I remember we at one stage, the end of last year, we rang 717 ladies post-section over a week or so period. And it was just astounding. The delight to be contacted, it was great to hear from you, and it's great that you want to know how we're getting on, because I suppose you have these prima gravidas going home and they've been monitored so closely, weekly, towards the end of their pregnancy. And it was just, there was that delight. And we came away from it thinking one of the big lessons here is hearing back from them. And then what we didn't expect to be doing, we rang them with the intention of finding out how their wound was, but we found ourselves jotting down, the team were fantastic and thank you for this. And it would be great if we were seen back. I wasn't sure what to do with my wound. It would be lovely to have a brochure and it's these kind of interactions that inform, they're telling us how we could do better. And that's what we want to know. Tell us how we can do better. And taking the patient's perspective on board is, I think, it drives further success, gives you confidence because, as you say, that confidence and the success piece, that you're confident that the patients want this. And if the patient wants it, it has to be successful if you deliver on it.
I mean, were they able to give you any feedback then in a not having to make a complaint way about negative aspects, things that could be improved in a sort of a safe discussion rather than that wasn't very good and here's a really angry letter to the chief exec or something like that?
Yeah, you see, and I suppose, being like I work in the South-Southwest Hospital Group, which is, I suppose, akin to a trust, so there's 10 hospitals in it. So, I mean, it's the onus is on each of us to take the feedback and to do something with it. It can't just be about a patient is speaking to us about our service. So, yes, we've taken any complaints back. And we actually, for a number of people in all cohorts we've looked at, we've gotten organised appointments for them to come back in if there's something we're concerned about. Because, and I mean, but it's rare, I wouldn't let that put people off. And we've fed back the positive feedback because I think that's really important, So, yes, we've made posters out of feedback with just captions. The positive and the negative are in there.
Yeah.
Yeah. I mean, and one of the negatives is really with all cohorts is we could be seen more often. Would have loved to seen the surgeon a few weeks later. That option wasn't given to me, told to go back to GP. And I suppose a bit of a disconnect. And I suppose the key thing for me, in relation to surgical site is there was that disempowerment that they did not have the knowledge. And we should be giving them more knowledge on wounds. We should be and the opposite side as well. A red wound isn't always an infection. And being put on an antibiotic in this day and age, possibly by an out-of-hours GP, or just to be sure, I suppose, is we need to be doing our bit from the hospital side to make the patients more aware that a red wound is a healing wound as well, that red at the edge of the wound is a healing wound.
Again, it's about education, isn't it?
And
making sure that people actually understand the whole process all the way through. Really.
Yeah, yeah.
Okay, that's been fascinating. What's next for you now?
Well,
where are you going next?
Yeah, so I'm a director of nursing in the South-Southwest Hospital Group, and my remit is deteriorating patient, I suppose, incorporating sepsis, surgical site infection, and I do the vaccinations legacy now from flu and that. But I suppose I just would like to finish my PhD this year, to be fair. And what's next for me? I am passionate about surgical site infection, and I'm delighted to be part of the surgical site infection initiative run there by Lillian, where I hope I say her name right, a passionate lady. And
you did.
Yes, and it's nice to be
Very.
It's nice to be involved in that, and because learning so much from that. And I'd hope to help the Irish like-minded people to get more involved in that. I suppose the next thing for me is hopefully we're running a masterclass here next month, and you have kindly agreed to facilitate a session in it. And this is the start of our journey as we open our minds, and I bring, infection control nurses, surgical site nurses, and hopefully a few surgeons to the room to listen to the journey and that you've had, and a few snippets of what's happening in our own hospitals. And we're just starting our journey here. We're learning from our colleagues. And I think that's what it's all about, not to reinvent the wheel.
It's continuous learning, isn't it?
It is continuous learning. And it's learning from the success stories. Like, I'm not incorrect here, correct me if I'm wrong, but you're at it over 20 years in the UK, and we can learn so much from you. We're really excited about what's about to happen, and hopefully we can catch up to you some way soon. Yes,
or even overtake.
Oh yes,
It's all about opportunity, though, isn't it? It's all about opportunity, and here's a big opportunity to make a difference.
And AMRIC, in Ireland, are engaging, and they have put a clinical nurse manager into each of our 6 to 7 regions here in Ireland, or trusts, as you'd say, to help roll out this, which is very welcome. So watch this space. We're going to be doing a lot more here.
Okay, that's been fantastic. I've really enjoyed chatting to you as ever. Look forward to seeing more of your outputs, and good luck with the rest of the PhD. And thanks very much for sharing the time. Thank you very much.
Yeah, thanks, Martin.